Good morning, everyone. Welcome to another wonderful High Rounds, last of October. And we have a new speaker who was recommended by a few different people, but Dr. Heather Pines said that we just had to hear Will Egers speak. So, and I'm so sorry, is it Eager or Egger?
That's perfect. Eager.
Both?
Yeah. Eager,
Eager.
eager. No. Yeah, eager.
Eager. Okay, good. So I think this should be, this is a topic that we all are very interested in right now. And I will introduce Will. He received his Bachelor of Arts in Public Health and Spanish from Hartwick College and a master's in public health from the Yale School of Public Health with a concentration in infectious disease, epidemiology, and global health. He's now on the NIDA T32 pre-doctoral fellowship in UCSD SDSU's joint doctoral program in interdisciplinary research on substance use. His research focuses on implementing HIV and other infectious disease prevention strategies among people who use drugs and inject drugs using a combination of harm reduction, implementation science, and mixed methods techniques. So I will turn it over to Will. We are very happy to have you here. Enjoy.
Yeah, thank you so much, Dr. Blumenthal. We're really excited. I'm really excited to be talking about my work today. Over the last year, and just like a full disclosure, this is my first time giving a talk of all my work. So I welcome feedback and comments about how it was delivered and what I included and what I excluded. So this is a great time to be receiving feedback and to be here. So I just appreciate your time today. But with that said, I'll be mainly focusing on my work that has looked at tailoring HIV prevention programs for people who inject drugs. So I have no conflicts of interest to disclose, and here is our funding. So here's a brief outline of what we'll be going over today. We'll start with an introduction and talk about the intricate link between injection drug use and HIV. Then I'll talk about HIV prevention for people who inject drugs and what that toolkit looks like. I'll try not to spend too much time on this, as I know so many of you are experts in HIV prevention and treatment. And then we'll move on to the first study that I'll really dive deep into today, which looked at general PrEP awareness and interest in long-acting injectable PrEP among people who inject drugs in San Diego and Tijuana. Then we'll look at a second study pretty deeply that I conducted last year about PrEP programmatic preferences among people who inject drugs in San Diego. And then I'll give a brief overview of my ongoing and future work, and then have some time for concluding remarks and discussion. So as you're likely aware, there's about 30,000 incident HIV infections annually in the United States. And around 1 in 15 of these infections are among people who inject drugs. And people who inject drugs are not only at elevated risk for HIV, but then are a priority population for prevention because they not only bridge HIV infections to their sexual partners and those social networks, but also their injection networks. So it's kind of this duality of risk that we're really increasingly interested in people who inject drugs to prevent future HIV infections. And unfortunately, due to vulnerable geographic challenges, such as lack of access to resources like certain services programs, we're seeing HIV incidence increase in people who inject drugs for the first time in decades. So there is a solid toolkit for HIV prevention for all key populations, but also for people who inject drugs. And these are kind of highlighted on your screen in this black box. They include condoms and safe behaviors, antiretroviral-based prevention, which includes treatment as prevention and HIV pre-exposure prophylaxis. We have voluntary medical male circumcision and harm reduction interventions, like I previously mentioned, like syringe services programs and exchange. But today, I'll be mostly focusing on HIV pre-exposure prophylaxis for the prevention of HIV. And one really great thing that we'll dive into a little bit about PrEP is that it can help disrupt the risk from injection drug use and high-risk sexual behaviors that are result from ongoing substance use. So pre-exposure prophylaxis is highly effective at preventing HIV, but remains relatively underutilized among this population. Maybe I shouldn't even say relatively, like it's just super low use. But oral PrEP has been the dominant HIV pre-exposure prophylaxis strategy over the last decade, and it has been shown to reduce the risk of HIV from sex by about 99%, and at least 74% from injection drug use when taken as prescribed. Adherence with PrEP is a challenge. People really have to be taking PrEP mostly every day of the week in order to be seeing these benefits, which we'll talk about in a little bit. With that said, PrEP awareness and use is extremely low in this population at around 25% awareness and 1% use. But that's not to say that people who inject drugs aren't interested in PrEP. About 60% are interested. So what we'll be talking a lot about today is how do we get these numbers for awareness and use closer to this interest number? And then, of course, how do we get interest higher as well? So I won't belabor this chart too much, but I kind of created this to talk about the development of HIV pre-exposure prophylaxis over the last decade. And some notable things are, one, that it starts in 2010, right? So PrEP and its related formulations are a relatively new technology that really people at UCSD have been kind of at the forefront of describing, especially for people who inject drugs. But it really started in 2010 with the results of the IPREC study, which showed that PrEP can reduce the risk of HIV infection among HIV negative men who have sex with men by around 44%. And then to fast forward, because you're most likely aware of all this information, in 2018, as shown on the last slide, the CDC first cataloged PrEP awareness and use among people who inject drugs. And generally speaking, these numbers, 25% and 1% respectively, haven't changed in the last 5 years, as we'll talk about in the two studies that I highlight. These are, you'll see on my slides, but this is kind of where we're sitting at in San Diego. And then one really exciting thing, which we'll talk about in both of my studies today, is that in 2021, the FDA approved long-acting injectable PrEP, but unfortunately, the study excluded people who inject drugs, which again we'll dive into a little bit more deeply in a little bit. So you might be wondering some distinct differences about oral PrEP versus long-acting injectable PrEP. So I created this slide just in case you're not aware, and it really does inform a lot of the information that I'll talk about today. So oral PrEP is a pill, again, that's taken daily. It requires a high level of adherence, as I mentioned, where people really do need to be taking this almost every single day. It's now offered as same day. So people go into the clinic, they get rapid HIV testing, ensure that they're HIV negative, kind of do like a survey, make sure they don't have any contraindications. They get prescribed PrEP, and then they go in for confirmatory testing. But again, unfortunately, people who inject drugs have been more or less, left out of these same day recommendations because of concerns about follow-up and adherence with PrEP. And PrEP is usually given as a 90-day prescription. And then you have long-acting injectable PrEP, which again was just approved in 2021, which is an intramuscular injection, so a slightly different formulation. The second dose is received 1 month after the first, but then every subsequent dose is given every 2 months thereafter. So you can see that there's some distinct differences here, right? It's the formulation, it's the frequency, and really it's the adherence where we kind of start seeing some differences here. Great. But while people who inject drugs have kind of been left out of long-acting injectable PrEP research, especially the clinical trials looking at its efficacy, there's not a lot of research on PrEP in long-acting injectable PrEP interest in this population either. One really great paper on long-acting injectable PrEP interest in this population, however, was run by Dr. Bazzi, who's one of my main advisors here at UC San Diego, which showed that most participants preferred injectable PrEP over other modalities because they viewed injectable medications as convenient and non-invasive and familiar. So we know that PrEP is really central to ending the HIV epidemic globally, but we need to do more to understand people who inject drugs' interest in these various formulations, especially these novel PrEP modalities that are coming onto the market. So to do this, we've kind of been centering our research on the motivational PrEP cascade. And let me walk through this with you a little bit. So the motivational PrEP cascade is really based on the trans-theoretical model of change, which posits that individuals move through these kind of 5 steps on the screen now: pre-contemplation, contemplation, preparation, action, and maintenance. And for each stage of change, different intervention strategies are most effective at then moving the person to the next stage of change and subsequently through the model to maintenance down here, which is the ideal stage of behavior. And in our population, because there's such low awareness among people who inject drugs, we've really been focusing on these 2 early stages, PrEP pre-contemplation and PrEP contemplation, which kind of ties into this idea of, 1, PrEP awareness, right? We need to increase awareness of PrEP so that way people can be thinking about, okay, is this good for me? And then PrEP contemplation, where we're thinking about PrEP interest, right? So if there's not a modality that people identify with, are they going to be uptaking this intervention? So ultimately, our questions related to this talk have come down to how can we help PWID move through this cascade to increase the number of people taking PrEP? So that brings us into study 1, which again focused on general PrEP awareness and interest in long-acting injectable PrEP among people who inject drugs in San Diego and Tijuana. Our objectives of study 1 were to examine the effect of social vulnerability, including factors like homelessness and interactions with the police, and behavioral factors, including injection practices, among others, that I'll describe later, on general PrEP awareness and long-acting injectable PrEP interest among people who inject drugs. So our first study took place in the San Diego-Tijuana border region and was based on baseline surveys collected between October 2020 and 2021 from the La Frontera cohort study, which has the overarching goal to track trends in the incidence of HIV, hepatitis C virus, and drug overdose in the context of binational drug markets between San Diego and Tijuana, Mexico. We had trained outreach workers who went into the community using mobile outreach and went to places that had a known high prevalence of drug use or known places where people who inject drugs or use drugs hang out to recruit participants for the study, which included people who injected drugs in the last 30 days. And then to get the information for our PrEP interest variable, which I'll go on to talk about, and PrEP awareness, we used computer-assisted personal interviewing. So our outcome 1 was, again, general PrEP awareness. And we first started by reviewing the literature to identify exposures hypothesized to affect general PrEP awareness among people who inject drugs. Then we constructed DAGs to depict causal interrelationships among our exposures of interest, outcomes of interest, and relevant covariates to identify variables to control for confounding. And in this case, we used modified multivariable Poisson regression with robust variance estimators to look at our outcome of general PrEP awareness, which was a binary indicator of either they were aware of PrEP or they were not. And our exposures in this case included homelessness, several injection behaviors, which I'll dive deeper into later, sexual behaviors, again, multiple, and then perceived risk of HIV. Then our second outcome, which was a little bit more novel in this case, looking at PrEP modality interest, we started again by reviewing the literature and using that preliminary qualitative data from Dr. Bozzi to identify exposures hypothesized to affect PrEP modality interest in this population. And then again, we used DAGs to kind of identify the relationships between our variables and hypothesized exposures, and used multivariable multinomial regression to examine the relationship between PrEP interest and these exposures. And let me dive a little bit deeper into our outcome here because it's a little bit more nuanced than the PrEP awareness one. So we asked participants what kind of PrEP product they would be interested in taking. And this was a select all type question that then was categorized into these 4 outcomes that you see on your screen. So we had oral PrEP only, long-acting injectable PrEP only, both oral PrEP and LAI PrEP, and neither. But the way the survey asked it was in this way. So option A was a pill I need to take every day. Option B is an injection I need to get every 2 months. Option C was a vaginal gel I need to use before sex. And that was only asked of women. And then option D was none. Like, I don't want any of these PrEP options. We then, again, categorized this outcome as oral PrEP only for participants who said that they just wanted the pill every day. LAI PrEP only for individuals who said that they just wanted the injection every 2 months. Both oral PrEP and LAI PrEP only, and LAI PrEP for people who selected A and B so that they were interested in the pill and the injectable, and then neither related to this research question. And just a note is that only one person wanted the vaginal gel, so we included them as neither in this analysis. And our exposures of interest in this case were included some additional variables, including police interactions and PrEP awareness, which we hypothesized would modify how somebody would be interested in PrEP. So our sample included 563 people who inject drugs. Their average age was about 43 years. Most were assigned male sex at birth and Hispanic. Past 6 months, substance use behaviors that increase risk for HIV were relatively common, including polydrug use at around 77% and receptive syringe use at about half. People also experienced various social vulnerabilities, including experiencing homelessness and being stopped by law enforcement. Past 6 months sexual behaviors were actually less common. And this is an important point when talking about PrEP for people who inject drugs, because if we again continue to just focus on sexual related behaviors for indication for PrEP and recommendation, we might be leaving out a solid proportion of people who inject drugs that could benefit from PrEP. And you can see that, around half had used substances before or during sex, but and around 12% engaged in transactional sex. In this sample, awareness of PrEP was a little bit lower than the national averages that I shared with you at around 18%. But unfortunately, only 2% had ever used PrEP, and only one person was currently on it. And around 30% had a high perceived risk of HIV. So here are the results from our first outcome, general PrEP awareness. So note that each exposure was examined in a separate multivariable model with variables selected for inclusion to control for confounding depicted in our DAGs, which I don't show here, but highlight at the bottom. So let's start with our variables that were significant. So generally, the prevalence of general PrEP awareness was higher among those who were homeless, who injected fentanyl, and had participated in transactional sex. So for people experiencing homelessness, how you would kind of look at this is that it is adjusted for age, country of residence, education, ethnicity, and sex assigned at birth. And though it's not statistically significant, the confidence interval is definitely quite wide. It includes one. It's interesting to note that participants who thought they were more likely to get HIV actually had a lower prevalence of PrEP awareness. So this kind of shows, again, like a just disjoint between how people who inject drugs are receiving information about PrEP and what their risk might be. So now to move into our second outcome, which was PrEP modality interest. About 16% had no interest in PrEP at all. 1/4 were interested in long-acting injectable PrEP only. 44% were interested in oral PrEP only, and 15% were interested in both oral and LAI PrEP. So in this analysis, we were specifically interested in people who are interested in long-acting injectable PrEP only, because again, like if we continue these recommendations where we're leaving out people who inject drugs from LAI PrEP and only offering them oral PrEP or other formulations, who are we missing out? So we were trying to find out what factors are related to this variable directly in comparison to oral PrEP to again highlight who would be left behind if we don't update these recommendations and get more access to LAI PrEP for people who inject drugs. So in this graph, I know it's a lot to take in, but let's just start at the top. So we're looking at associations from our multivariable multinomial models, comparing interest in oral PrEP only to long-acting injectable PrEP only among our sample of 563 people who inject drugs. Our reference group here is long-acting injectable PrEP only. An odds ratio less than 1.0 indicates that those individuals that are more interested in LAI PrEP indicates that those individuals with those characteristics are more interested in LAI PrEP than oral PrEP. So one example interpretation of this is that compared to the odds of being interested in long-acting injectable PrEP only, the odds of being interested in oral PrEP only were lower among those who are experiencing homelessness. The effects were in the same direction for a number of other exposures as seen on your screen. And again, these are just the ones that were significant in this analysis. And what that means is that the odds of being interested in oral PrEP only were lower for people who injected fentanyl in the past 6 months, people who had poly drug use in the past 6 months, people who had injected multiple times per day in the last 6 months, people with receptive syringe use in the past 6 months, people who had substance use before or during sex in the past 6 months, who were stopped by law enforcement in the last 6 months, who thought they were more likely to get HIV, so who had higher HIV risk perception, and then for those individuals that were not aware of PrEP. So some conclusions from this first study included that less than 1 in 5 people who inject drugs were aware of PrEP, with people who inject drugs experiencing homelessness, injecting fentanyl, and engaging in transactional sex being more aware. And we also saw that participants with high perceived risk were less likely to know about PrEP. About 25% of people who inject drugs in our sample were interested in long-acting injectable PrEP only, with about 15% more interested in both LAI PrEP and oral PrEP. And the most socially and behaviorally vulnerable people who inject drugs were only interested in LAI PrEP. So for example, many high-risk injection behaviors were associated with participants being interested in LAI PrEP over oral PrEP, and participants who were homeless and stopped by law enforcement in the past 6 months were also more likely to be interested in long-acting PrEP over oral PrEP. Also, those with high perceived risk, not aware of PrEP previously, and using substances before or during sex were all associated with greater interest in LAI PrEP. And what's notable here is that these individuals, based on these characteristics, are probably the most likely to experience challenges with daily adherence and safeguarding medications. So for example, if you're experiencing homelessness and not able to lock up your medications, they could get lost or stolen, or especially now with all these crazy street sweep bans, could get, their stuff taken by authorities. So LAI PrEP could be their best option. And then ultimately, offering various PrEP options, including LAI PrEP, will ensure that no people who inject drugs who want to who want access to PrEP are left behind. And further research is really needed to increase PrEP awareness and inform the implementation of LAI PrEP among people who inject drugs. But one limitation of study 1 is that we did not assess the frequency of use and modality separately for PrEP. So for example, we asked participants to choose from a once daily oral pill versus an injectable PrEP that they could receive every 2 months. So for those folks that were only interested in long-acting injectable PrEP, it's unclear if they are more interested in the injectable formulation or its long duration, for example. So ultimately, we kind of had these additional questions of like, what is driving preferences for these various PrEP modalities? You know, why is this 25% of people interested in LAI PrEP only? And are there other programmatic decisions like support services that can make that we can make as researchers and interventionists to advance PrEP interest and uptake among people who inject drugs? And that kind of leads us into study 2, where we looked at PrEP programmatic preferences among people who inject drugs in San Diego. I'm just going to pause to take a sip of water, but are there any important questions that we should look at?
There have been there have been a few things discussed. I think most of it has been answered, but Larry had a question. A lot of people are interested in the participants from TJ, knowing that the access is lower. So Anik said that the district, that it was about 70% San Diego participants, 30% TJ. And I think that answered that, but then who are your partners in TJ? And did participants have visas so they come to San Diego to receive injectable PrEP? Sort of what did that mix look like?
Yeah, so my understanding of this study is that it's completely observational. So we're not actually administering injectable PrEP. In this case, we were just interested in hypothetically, are you interested in injectable PrEP, oral PrEP, a vaginal gel, etc.? So these were really conducted in a larger mixed methods observational cohort study. And just, this assessment was based on several questions included in that. But our partners for help in that regard are, we have an ongoing study team that is binational. So we have partners and team members in Tijuana and in San Diego that do mobile outreach in both locations. And they're people who live in San Diego and Tijuana, including project directors, research assistants, etc. And we also partner with, I can't say the university's name. Anik, maybe you can help me with that. It's Xochicalco University in Xochicalco in Mexico, who has some researchers that also assist us. But Anik, I don't know if you want to speak more to that, if that's what your comment is.
I semi-answered Nettie's question, but she was interested in understanding the distribution of awareness and use, previous use by city. Because the expectation is that all of those who had experience of use, which I think was only 3, were San Diego participants. But I don't know how it looked for adherence. And maybe the use also, we're assuming wrongly.
Yeah, I actually didn't. So for awareness, that would have come up in the analysis here. So it was not being on one side of the border was not associated with awareness. However, use, we didn't examine. I can hypothesize that the 3 people were probably in San Diego, but I don't want to say for certain because I don't recall what that
I can
like.
actually help with that, Will. They were all
thanks.
they were all in San Diego, so there weren't any in Tijuana that were interested, or sorry, who had previously used PrEP. Just the 3 from San Diego.
Perfect. Okay. All right, let's move forward. Thank you so much, everybody. I hope I was able to address your questions. And if not, please feel free to follow up with me at the end, and I can email anything that wasn't necessarily clear or that I wasn't able to address right now. I muted myself. I don't know why I did that. Okay. So the objectives of study 2 were to assess preferences for PrEP program characteristics among people who inject drugs, including PrEP modality, frequency of use, service location, prescription access location, and adherence supports. And to explore differences by hypothesized modifiers of preferences, including sex assigned at birth, housing status, injection frequency, and prior PrEP awareness. So to assess these preferences for various PrEP program characteristics, we used a market-based research technique called a discrete choice experiment. DCEs simulate consumers' decision-making process by presenting participants with sets of choice alternatives that vary with respect to key product attributes, such as in this case, PrEP modality or frequency of use. And then we ask participants to choose an alternative within each set. The probability of choosing an alternative is then modeled as a function of product attributes to identify preferred attribute values and the relative importance consumers place on each attribute when choosing between alternatives of our product. And while discrete choice experiments have been used to assess individuals' preferences for PrEP before among men who have sex with men and transgender women, they remain underutilized among people who inject drugs. So this specific survey was conducted only in San Diego with a population of around 260 people who inject drugs. They were cross-sectional surveys collected between May 2022 and June 2023 using a very similar format to the larger observational cohort study, La Frontera. And to recruit participants, our study team used community and mobile outreach and then asked participants to take these interviewer-administered computer-assisted surveys that included our discrete choice experiment. Our DCE included 18 different PrEP program scenarios that were presented to participants in sets of 3 via the DCE survey. And what you're seeing on the screen now is one of the 18 different scenarios shown to participants. Before presenting the program scenarios, interviewers provided a brief introduction to PrEP and the PrEP program characteristics with examples to facilitate comprehension. Afterwards, participants were asked to choose their preferred scenario within each set, where each set also included a none option, which you can actually see at the bottom here. Our scenarios consisted of various combinations of PrEP modality, frequency of use, service locations, access locations, and adherence supports based on prior PrEP acceptability and DCE studies among other populations. So for example, in this set, let me point your eyes towards option 1, which included the PrEP modality option of an implant. Frequency of use was annual. The PrEP service location option in this case was a community-based organization. The PrEP access location was on-site, and adherence supports included social supports like friends, family, and other people close to you. You can also see in the other options, so option 2, for example, and option 3, that frequency of use requirements in general included every 2 months and daily. Other service locations included clinics and telemedicine. PrEP access locations included on-site as seen in option 1, but also street outreach and mail delivery. And then lastly, you can see that adherence supports included, in addition to the social supports, street outreach workers and phone/text reminders. And for this analysis, we used a multinomial logit model to model the probability of choosing a single PrEP program scenario as a function of the 5 program characteristics. So from this model, we estimated 1, relative importance scores, which reflect the relative influence of each characteristic on choice. And then 2, part worth utility scores, which reflect preferences for specific characteristic values relative to the reference value for each characteristic. So to explore whether part worth utility scores and relative importance scores varied by sex assigned at birth, housing status, injection frequency, and prior PrEP awareness, we also fit stratified models. In this case, our sample included 262 people who inject drugs that had a mean age of about 43 years, There were about 30% female assigned sex at birth, 60% were Hispanic, and 70% were experiencing homelessness. We also assessed various injection-related HIV transmission risk behaviors and saw that a majority of participants injected multiple times daily, and about 1 in 3 injected with a previously filled syringe in the past 6 months. And tracking with other published literature, as highlighted earlier, about 25% of people in this sample were aware of PrEP, but again, only about 3% had ever used it. The first set of results that are now on your screen show our relative importance scores that resulted from our multinomial multi-logit model. Relative importance scores, or risk values, again, represent the relative influence of each characteristic on choice. So risk values that are greater in magnitude have a greater influence on someone's choice. So in this case, for the total sample, since frequency of use had the highest risk value at 52, it had the greatest influence on participants' PrEP program choices. The next highest risk value was for modality at 35, so it did not influence participants' choices as much as frequency of use, but it was more influential than adherence supports, service location, and prescription access location, which were all much lower than frequency of use and modality. And for our stratified analysis, as you can see, the risk values didn't differ super meaningfully, except for the case, and I'll dive into this a little bit more with the part worth utility scores, but you can see that people who are aware of PrEP had a more balanced like importance scores, and that adherence supports in particular were more important to this group. And there was actually a switch in the second to last most important option from service location in the total sample and people not aware of PrEP to prescription access location, and then service location last. There we go. Yeah, slight change in influence. This second set of results highlights our part worth utility scores for the total sample, which reflect preferences for certain levels within each characteristic. So positive part worth utility scores, as you see for frequency of use with annually, indicate a relative preference for that value, and negative part worth utility scores indicate a relative aversion to that value for a characteristic. So for frequency of use, for example, the part worth utility score for annual use was 0.83, indicating a strong relative preference for annual use, while the part worth utility score for daily use was negative 0.76, which indicates a relatively strong aversion to daily use. And for every 2 months, you can actually see, and interpreting this, basically a value of 0.1 or lower was kind of indicating to us that there was really no preference either way for that given attribute. Now to move on to modality, which was, again, the second most influential attribute in people's decision-making, as indicated by the relative importance scores. Participants tended to prefer oral PrEP compared to the others, but really they didn't have a preference either way for injectable PrEP, but definitely didn't prefer implants. And then with adherence supports, which was technically the third most influential attribute, participants seemed to prefer phone-based support. However, for both service and prescription access locations, we saw that participants in our sample generally had no preferences regarding these attributes, with all the part worth utility scores being less than this like 0.1 threshold that we developed. And while not shown, these associations also held true regardless of sex assigned at birth, housing status, or injection frequency. And I'll highlight the part worth utility scores for by PrEP awareness on the next slide. So for individuals who are aware of PrEP, and we can remember that, these people had weighed slightly more importance on adherence supports and prescription access location than the total sample. You can see that there did emerge to be some preferences in the part worth utility scores for phone based adherence supports and mail-based prescription access. But again, for people who are not aware, the relative importance was so low that really for these part worth utility scores, we again don't really see a preference. So what this tells us is that frequency of use requirements and modality may drive PrEP program engagement among people who inject drugs, regardless of potential modifiers. And adherence support, service location, and prescription access location hold relatively little importance in PrEP program decision making. However, people who inject drugs with prior PrEP awareness have a more balanced preference in general. And novel PrEP formulations that aim to decrease frequency of use requirements in an oral format may increase PrEP uptake and persistence among people who inject drugs. And then also, I'd like to note some consistencies with study 1. So first, we saw that oral PrEP was preferred in both studies, greater than 40% in study 1, and then, preferred here for modality. And however, in study 2, we saw that frequency of use was the most important. So if long-acting oral PrEP is not available or never developed, long-acting injectable PrEP could wind up being preferred among people who use and inject drugs. Okay, so now I'm going to do just a quick...
Will, just really
Yes.
quickly, there was a question from Nettie. So there was no difference in the answers by housing type, was what she asked.
That is correct.
But in the
Yes,
last
that is
study, we
correct.
saw a preference for injectables in people who are homeless.
Yes, so in our interest work, we did see a preference for injectable for people experiencing homelessness. But then in the discrete choice experiment, we did not see that. And what we kind of largely attributed that to was our smaller sample size to be able to detect those, both relative importance scores that were then, stratified by these various characteristics, but then also for the part worth utility scores, which then really get impacted by those larger relative importance scores. So hopefully that answers your question. We do think, that this was really a strong hypothesis for us going into the discrete choice experiment, that people experiencing homelessness would be more interested in or more, way more importance on the frequency of use. Especially longer frequencies of use, but unfortunately, we didn't see it. And they were two different populations. Study 2 was just in San Diego, so that's a really good point. So thank you. Awesome. And we can discuss that more at the end too. I'm hopeful we'll have around 10 minutes for discussion. Great. So one study that I've been working on recently has been an evaluation of Boston Healthcare for the Homeless program's low barrier PrEP program for people who use drugs experiencing homelessness. The larger aim of this evaluation was to examine sociodemographic and behavioral factors associated with receiving no PrEP, an initial PrEP prescription, and then refills for PrEP. So this population included 509 people who use drugs attending Boston Healthcare for the Homeless program's low barrier PrEP program between October 2018 and September 2022. Our outcome included the number of times a participant picked up or filled a PrEP prescription from the pharmacy. And for this analysis, we created a nominal 3-level variable to indicate whether a participant did not fill a PrEP prescription, so 0 times, filled exactly 1 prescription, or an initial, or filled greater than 1 prescription after enrollment into the program. And using this study used electronic medical records and internal tracking systems from Boston Healthcare for the Homeless program to extract data from HIV negative people who use drugs reporting sexual, drug, or community-related HIV exposures. And then we use adjusted multinomial logistic regression to estimate odds ratios for sociodemographic and behavioral factors associated with receiving our outcome. So our sample wound up being about having around 78% of people who had recently injected drugs in the last 30 days. 71% had a mental health disorder of some kind, and 92% were experiencing homelessness of some kind. Excuse me. In our multivariable adjusted models injection drug use was actually positively associated with receiving an initial PrEP prescription and refills. So people who injected drugs were actually 2.88 times as likely to receive an initial PrEP prescription than people who had not injected drugs, for example. And then clients with generalized anxiety disorder, any substance use disorder, and opioid use disorder were more likely to receive an initial PrEP prescription and refills, while those with bipolar disorder were less likely to receive an initial PrEP prescription. And then sexual behaviors and other mental health and substance use disorders were not associated with our outcomes in either direction. Okay, so then the second study I'd like to talk about that I'm currently evaluating is the Florida, or not a study, but a real world implementation of an HIV self-testing program by the Florida Harm Reduction Collective. So the aim of this evaluation was to assess the impact of the real world implementation of a peer-based and male-based HIV self-testing program delivered by the Florida Harm Reduction Collective across the state of Florida on the uptake of HIV testing among people who use drugs, and to examine differences in the characteristics of participants that utilize each strategy. So this population included 728 people who use drugs enrolled in their HIV self-testing program between October 2022 and June 2023. We used descriptive statistics and adjusted Poisson regressions with robust variance estimators to examine the relationship between sociodemographics and then the HIV epidemic county designation, previous HIV testing experience, and type of HIV self-testing distribution strategy, peer or male-based. We found that this sample included around 47% assigned female sex at birth, 55% were non-white, and 52% were from a minority sexual group. Ultimately, 55% of people who wound up getting tested in the program had no prior HIV testing experience. 66% were from an EHE county in Florida. And the likelihood of receiving male-based HIV self-testing compared to peer-based testing was significantly lower for cis males, non-Hispanic Black participants, and participants from EHE counties compared to their counterparts. And compared to individuals who were straight/heterosexual, participants who reported other as their sexual orientation were more likely to receive a male-based HIV self-testing kit than a peer-based kit. So now I'll move on to some concluding remarks and discussion. So overall conclusions from these 4 analyses/studies are that 1, people who use drugs are interested in PrEP and novel PrEP modalities, but awareness remains an issue. Novel PrEP formulations that aim to decrease use requirements in an oral format may increase PrEP uptake and persistence in people who use drugs. People who use drugs can successfully initiate and continue PrEP-related care given the appropriate supports, which unfortunately I didn't describe in detail today, but I'm happy to talk about to the best of my ability. And then 4, community-based HIV self-testing is an effective means of increasing HIV testing uptake among people who use drugs, especially those in EHE jurisdictions. Some future directions from all of this work are 1, dissemination and implementation research on PrEP for people who use drugs. So 1 is like, how do we increase awareness? And 2 is efficacy and implementation research on LAI PrEP. 2, better tailored and more consistent marketing of PrEP to clinicians and people who use drugs to increase awareness and likelihood of engagement. And then lastly, new investments to increase awareness and delivery of novel HIV prevention programs like long-acting injectable PrEP and HIV self-testing for people who use drugs. Lastly, I'd just like to thank our community collaborators and participants and acknowledge the rest of the authors on this project, particularly Dr. Angela Bozzi, who's my main advisor through my PhD program, and Dr. Heather Pines, who encouraged me to come give this talk and meet with you all today, and who's been instrumental in every one of these analyses. And then, of course, our other co-authors and people at Boston Healthcare for the Homeless Program and the Florida Harm Reduction Collective. So thank you so much, and I'll open it now to questions.
Looks like Bobby Dice has his hand up. And if people want to show their faces, this is a lovely time to do that, if you can.
Sure. I'm I'm driving. I just
Sure,
had to get in
then
the
I don't
car,
want
so
you to.
so
Yeah.
I won't. But thank you. No one wants to see me anyway. No, great talk. Thank you, Will. It's nice to see this work going forward. I wanted to ask about the cabotegravir tail. The sort of pharmacokinetic issue of cabotegravir being very long acting. I'm curious if your surveys or sort of interviews have asked about that. We put together a proposal recently. Angela was involved, to CHRP to try to implement this very issue, long-acting PrEP for people who use drugs. It's sort of like the greatest strength is the greatest weakness in terms of its long-acting. So what are your thoughts on that? And how much knowledge is there about that is sort of what I'm getting at.
Yeah. From my understanding of this work, we didn't assess that. I'd be interested. I don't think it was mentioned in the publication that resulted from the qualitative interviews that Dr. Bozzi conducted. But I wonder if those interviews did dive into that a little bit, and really the marketing for it in everything I've read and seen doesn't discuss it very much in terms of the outward facing documents for like participants and kind of people like me, right, who are researchers but aren't clinicians. So that's definitely one major limitation, I think, in talking about this issue. And I really like how you described its like greatest strength is its greatest weakness. And I am interested to see if that would actually influence people's interest. And
yeah, no,
yeah.
I think you make a great point that it's not really talked about in the marketing either, and maybe we're sort of stigmatizing a population and really only talking about this issue in the context of people who inject drugs that maybe we shouldn't be doing if we're not doing it for others. So anyway, yes, great talk, great points. Thank you.
Talk about it for others. It's not just in people who inject drugs.
Sure.
Yeah. But yes, I mean, I think it's been addressed. It sounds like it wasn't specifically asked, but I think that's okay. People who stop medications, that have the potential to stay, in the system longer are going to be across the spectrum. So I'm not sure why we would focus specifically on people who inject drugs. Well, this was great. One thing I wanted to raise, because obviously there's been a lot of talk about LAI PrEP. And when you're talking about that, you're talking about specifically cabotegravir. And as you probably know, and I think this audience knows, there are going to be other long-acting injectable formulations coming out. There already is lenacapavir, which is every 6 months. And I think it's really important when these studies are conducted to make sure that you're trying to take into consideration other preparations, other formulations. Because what I found when you bring up something and then all of a sudden you sort of bring a new product to market, or you say, here's this. Well, what happened to the other one? Why are we talking about something totally different now? I think making sure that people who are interested in this are aware that things are evolving and that we always have different things coming out, and to sort of gauge their preferences when it comes to that, I think is really important. So just as we're going to be a site for purpose 4, which is for people who inject drugs taking lenacapavir versus Truvada, and it is an every 6-month injection. And I hope the messaging isn't going to be confusing, where people are like, well, I thought it worked every 2 months, and so just thinking about that as you go out, and because I think a lot of these studies actually maybe you're making people aware, right? You're the people that are talking about it if they haven't heard of it. Sorry, that was very long-winded. I'm not even sure.
But yeah, I think it brings up a really good point about that the issues that I highlight with how PrEP has been marketed to date are really just to emphasize that like we need to be offering everybody everything at our disposal, so that way they have the opportunity to engage with the format that works best for them. So yes, these studies were like focused on LAI PrEP, and that by no means that we should get rid of oral PrEP and daily oral PrEP. Like 40, almost half of the people were only interested in that in our first sample, you know, it was clearly the favorite modality. And yes, daily oral PrEP is hard for people who are experiencing a lot of social and structural vulnerability, but at the end of the day, it's easy, right? You can take it on your own time. You can take it, you know, in the, you know, safety of your dwelling. So, you know, I think future dissemination research really, you know, and it's hard because you have like pharmaceutical companies that are very vested in trying to gain increase in their newest, latest technology. So then we see like, okay, let's like focus on the 6-month PrEP, and then people get, you know, like you said, confused or lost about these other options. So I'd be really interested in like more dissemination research about, okay, how do we like broadly you know, make people aware about PrEP, and then at least give them a baseline amount of information so that they can go to their clinicians and say, hey, this might be a good option for me. So thank you for the comment.
There are a few more comments here. I don't know if Nettie said, I'd love to have a community discussion on the cab long tail issue. Just because it seems like it's something that patients don't understand. And I don't know, so far, obviously it's very early, you know, for us in terms of real life implementation, or real world, that's what I meant. But it does seem like it is, you know, it's stressed. We discuss it with patients, and patients have been, and these are obviously early adopters for, you know, long-acting cabotegravir, but they seem to be aware of that. But I agree. I mean, it's something to obviously.
I think it's more of a, I was going to say, thanks, Jill. I think it's more of like a programmatic issue. Like when people come in for birth control, we give the shot of Depo on the way out the door. And when they come in for PrEP, we hand them a starter pack of PrEP same in the moment that they're there, which is really important. But for a long-acting injectable cabotegravir, I feel like we're not able to really give the education, and you know, I don't really want to do out the door cabotegravir because I just don't feel like. But I think that's something where people are thinking, oh, I'll pop in and get my same day shot. You know, as people sort of ask us for that, and we're like, well, we're not quite there yet.
Yeah, I mean, I think in general, because of the coverage, you can very rarely get same day injectable PrEP because there are authorizations and other issues that come up. But obviously, it's you know, it's something that will happen, right? And then, Will, I don't know if you saw the question from Larry, in addition to awareness about PrEP, awareness of payment for PrEP, and how, you know, if people know about coverage for PrEP, and
I would
that influence their perspective on taking it or not, or wanting to take it.
Yeah, so that's a really good point. Our discrete choice experiment, unfortunately, did not include cost. And I think that was, you know, made for very good reasons. So we can include other important kind of implementation characteristics in our discrete choice experiment. But in the literature at large, I think there was a conjoint analysis, which is like a similar market-based research technique to understand preferences for these type of things in among people who use drugs in other settings, that showed that cost was really important to people. So I think, you know, coupling this type of intervention and dissemination is with kind of what the options are for people cost-wise is going to be really valuable, because that, you know, in addition to like, what are the pros and cons, like a pro for oral PrEP, right, is that it's currently cheaper than long-acting injectable PrEP for a lot of people. So yeah, thank you for bringing that up. We didn't assess it here, I guess, is the summary, but you know, people are thinking about it and looking at it.
Because if I'm homeless, I'm thinking about where's my next meal going to come, and I'm thinking they're going to if you know, if I can't get a meal, why are they giving me PrEP?
Totally.
And it'd be the last thing on my mind as far as PrEP is concerned. And so I think that information needs to go out. Also, as far as the availability, as far as coverage, insurance coverage.
Yeah, I mean,
PrEP or PrEP LA through the state of California.
Yeah, I mean, you bring up a point that it was exactly, you know, kind of centered our hypotheses around this work, is that, you know, people who have all these other challenges going on in their life are we were like, oh, they're probably going to be more interested in these long acting formulations, so they don't have to go to the clinic all the time or have to remember to take their pill or, you know, worry about losing it. So yeah, thank you so much. I think you raised a great point. Anik, did you have a comment before we go? I know it's 9:01.
Yes, and I have to jump to another meeting, but I'll ask you another time. But thank you, Will. It was an amazing talk. Lots of
Thank you so much.
information.
Yeah, thanks so much, Will. It was wonderful having you. Obviously, great, productive dialogue. So, and yeah, I don't know, last word from you as we leave.
No, thank you so much. You know, if you have my contact information, I'll put it in the chat before I go. Please follow up with comments or feedback. You know, I'm a young PhD student, so it's really nice to get feedback and understand how I could be better. And thank you so much, Dr. Blumenthal, for leading today and moderating. I appreciate your time and everyone's time. So have a good one.
All right. Bye, everybody.